start with the first talk of the IC by Dr. Samaresh Srivastava, Nucleus Management in Large PCR.
Hello. Yeah. Good morning, and thank you, Dr. Manpreet, for inviting me for this instruction course. So I'll be discussing very specifically on nucleus management in case a PCR happens, and I'll discuss this on a case-based scenario. So this is a patient. I just want you to notice that one of my fellow doctors was operating, and I was called into the OR when the situation was like this, and I can make out that there is an area of extreme clearing at the distal end. It's a temporal surgery, so at the nasal half something is cleared up big time. And this generally, technically, if you see things clearer, then you should be wary of a PCR happening. The goal of, as a doctor, when a situation like this arises, is to, number one, prevent any vitreoretinal traction. That's the number one thing we want. And then finally, we want to see if we can salvage the nucleus and not let it sink, but that's not our primary concern. The primary concern shifts gears the moment this happens. My approach in a situation like this has moved from limbal to pars plana vitrectomy, because if you do a limbal vitrectomy, generally you enlarge the PCR, and if you have a nucleus in the eye, the nucleus will tend to drop off because it's like a zipper-like opening, as you can see over here. On the other, so if you look at the limbal vitrectomy that I'm doing over here in an experiment in a high-speed photography, notice that the entire vitreous body moves upwards, and notice how these sharp edges of PCR will open up like a zip. And this is going to cause a problem to us more often than not. If you do a pars plana vitrectomy, which is with the nucleus in the eye, if you approach the eye from the vitreous from the behind, you will be able to probably save that PCR from enlarging, and then you can tackle the nucleus at a certain time. So again, high-speed photography showing very tranquil environment with a pars plana vitrectomy, which means the vitreous cutter is behind the posterior capsule. So going back to that case over there. First thing first, we need to visualize what's happening. So I use triamcinolone, and as you can see over here very clearly, on that part there is vitreous that's already presented. When you see a vitreous, your first commitment is to clear the vitreous. I use a trocar cannula system, but you can use an MVR knife to make a slit entry into the pars plana area for 3.54 millimeters, and then do a vitrectomy. And notice whatever vitreous had come anteriorly has collapsed back into the posterior compartment in the area of the PCR. If you try to tackle the nucleus before you do this, and when you rotate the nucleus, the vitreous strands will get adhered to the nucleus body, and then you will cause traction, and sometimes you'll be chewing up the vitreous, and sometimes you'll be chewing up the nucleus and causing peripheral traction. But if you do a pars plana, it will not happen. Once the pars plana vitrectomy is done, now I can handle the nucleus safely because nothing is intertwined. But notice what I'm doing over here. I'll just pause for a second to show you again. Is I've split the phaco into two. My left hand has the irrigation and my right hand has the phaco probe. So I'm using a bimanual irrigation to keep the fluid such that the nucleus doesn't go down, while I'm using a phacoemulsification to emulsify the area of the nucleus, the remaining nucleus. Because it's a temporal surgery, I have to emulsify distally, right in the area of the PCR. But I'm able to do that with lower parameters and the fact that I separated the fluidics, the irrigation, from the aspiration. It's important to do a pars plana vitrectomy because you want a stable scaffold in a situation like this to put a lens inside. Which means that if you do a limbal vitrectomy, you can only do so much to clear up. If you see over here, you can only clear up only so much space and not a lot of vitreous behind the PCR to call a stable scaffold. So vitreous what is remaining will tend to push the nucleus, sometimes the IOL, sometimes out of the bag, and sometimes it will decenter it. On the other hand, if you do a pars plana vitrectomy, you will be able to clear it off way beyond the area of the PCR, thus giving you a very stable place and a stable bag where you can place the lens and the lens will stay centered. One thing for certain is, if a nucleus falls down like this, the last thing you want to do is fish out the nucleus, because as you can see over here, the vitreous body and those vitreous strands are so entwined with this nucleus that if you pull something, you are most definitely going to cause peripheral retinal traction and tear. So this is just to show you that if you land up in a situation where things have dropped, I think it's best to let it go and to let your retina surgeon handle this situation rather than we trying to do a fish hook or pulling this nucleus out. One more case, it's a young patient, diabetic with bilateral posterior subcapsular cataracts. This is how the picture looks, probably a steroid cataract. Phacoemulsification is pretty straightforward in this, and I'm just going to move out of this. So we do a 4-quadrant technique for softer nuclei because sometimes it's very difficult to prolapse them. And that followed by removal. I'll just go back over here. So while we were doing a bimanual IA, we realized that the PCR has happened. When a PCR happens, again, if you notice over here, we've gone for, instead of a limbal vitrectomy, into a pars plana mode. So right now there's a whole heminucleus in the eye over here, but we are leaving it where it is, and we are cleaning off vitreous in the area of the PCR. Now I don't know the extent of the PCR, I don't know how big it is, what is the situation, but first I want to handle the vitreous body. Because if I don't do it, there is no way I'll be able to take out this nucleus en masse. Once I've done adequate vitrectomy and made sure that the area is clear and my anterior segment is clear of the vitreous, then I go ahead and I rotate the nucleus. And notice how I'm rotating it in the area of the PCR now, because I am certain that it's not going to drop or not get entangled with the vitreous. One more thing is always to do a bimanual. When you do an exchange of instruments, you use a dispersive viscoelastic. Now here again I have split my irrigation in my left hand and my phaco in my right hand, and I have prolapsed the entire nucleus out of the bag, and I'm doing an anterior segment phaco, but I'm keeping the irrigation. Again, if you notice, the IOP is 12, which means a bottle height of 50, and my flow rate is low. So I want to go slow when I eat. I don't want to chew up everything, and I want things visualized. And notice how big the PCR is. It's from edge to edge. There has been a split in the posterior capsule. And I'm keeping an eye, making sure nothing big falls down. But if it does, I'm not going to go and fish for it. I'm just going to let it pass. It's a compromised situation. So for me, the important goal is right now to maintain as much of the anatomy as possible. See if I can put in a lens, or if not, at least I don't do more damage than I already have done to the eye. But fortunately for me, the nucleus comes out quite comfortably. Bimanual IA, again, it's very important to use a bimanual over a coaxial because it keeps control and keeps your bigger ports away, and to use lower parameters. So again, my IOP, which is my bottle height in a non-active fluidics, is about 40-45 centimeters, and my flow rate is actually 4. 4 flow rate means driving a car at 10 kilometers per hour when you're used to 60, because you want to make sure that you're pulling the cortex and not the vitreous, and you want to visualize what you do. Again, I've cut it off in the interest of time, but this is all viscoat. So when you do an exchange of instruments to change from right to left, please exchange with dispersive viscoelastic rather than yanking out your instruments, or the vitreous may present. So this patient had a toric lens that was to be implanted, but because I was certain that the vitreous has been tackled, I'm going and putting the toric lens in the capsular bag. It's very important, again, when you have a choice of lenses, to use a hydrophobic lens and use a lens that opens up slowly and gives you adequate time for you to assess and for you to position the lens. So I know there is an open capsule posteriorly, but because years of confidence and the fact that I know the material well, it's where one can slowly but gently insert the lens. So I'm not dialing it or pushing it, but I'm using both instruments to slowly push the lens into place and to align it eventually into its desired axis. If there is the slightest doubt that it may not happen, it's best to leave it. And now the lens after that was captured through the anterior capsule. This is to show you the post-operative OCT. Macula looks okay. The lens is well centered, and it's an optic capture, which means the entire IOL is inside the capsular bag, but the haptics are out of the anterior capsule, lying anteriorly. And this is to show you patient at 3 months, fibrosis has set in, and the eye is quiet. So to conclude, if you land up in a situation where you have a PCR and you have a nucleus body in the eye, first handle the PCR. Visualize, use triamcinolone, use good cutters, clean the vitreous, because if something falls, the retina guy will take it out and the patient will see well. But if you try to fish it out so that you don't have to explain to the patient, you will have to do a lot of explaining for many, many months to come. So what's better is to do your job and just clear out the eye. Thank you.
So I have a question for Samaresh, like, do you prefer 23 gauge or 25 gauge pars plana?
So I'm using the 23 gauge as of now. I don't think the Centurion is supporting a 25 gauge vitrectomy. And I'm doing a vitrectomy out of a Centurion anterior segment. I don't have a vitrectomy machine as in posterior segment, but I'm not sure if 25 gauge cutters are supported. I would love to do 25.